1 minute.
Darshan?
Just 1 minute.
Sure, sure.
And we are live.
We are live.
Good evening, everyone. Welcome to the Divas virtual series on women's health. And today is day 1, and we are so honored to have Professor Moshe Hod as the keynote speaker. We have Dr. Hema Divakar and Dr. Anil Kapoor joining the panel of during the Meet the Professor. We also have some amazing moderators and takeaway and question and answer coordinators. But I just wanted to start by saying that these are such unusual times when the health system is stretched beyond belief. Dr. Antonio Guterres, the Secretary General of United Nations, has repeatedly said from the beginning, the best way to recover from COVID-19 or during the recovery of COVID-19, we should put girls and women in the center of the recovery. And I think that was something he started saying from the beginning, and we are learning that women are more vulnerable and affected by the economic downturn and the lockdown and the other effects of COVID-19. Gestational diabetes and diabetes in pregnancy in general has always been a challenging issue. But when you add COVID-19 to this mix, it becomes actually a collision course. And we want to talk about the different challenges that people are facing with gestational diabetes, COVID or otherwise. This is a most fascinating, constantly evolving, absolutely challenging area in medicine, and always fun to discuss. And I think we have a great panel that's going to do this for us. So I welcome you all to this program. Can I have the next slide, please? So just to give an introduction quickly about what Divas is, it's a non-profit initiative we started 7 years ago, and it stands actually for Diabetes in Women Awareness and Advocacy Strategies. The reason we started this is because we realized that diabetes in women is something different and difficult, dismissed, and actually quite deadly. But we have expanded the scope of Divas now to include all non-communicable diseases because women are particularly vulnerable to all NCDs, and we didn't want to limit our attention just to diabetes. Next slide, please. So I'm so grateful to Professor Hod, who heads the FIGO Pregnancy and NCD Committee for kindly and so graciously accepting to give the keynote address to us. Next slide, please. And I want to introduce the professors, Professor Moshe Hod, who we will be talking about now, and Dr. Hema Divakar and Dr. Anil Kapoor. Next slide. So Professor Hod is the Professor of Obstetrics and Gynecology at the Sackler Faculty of Medicine, Tel Aviv University, Israel. He's the chair of the Pregnancy and NCD Committee, FIGO, and member of the executive board of FIGO, and past president of the European Association of Perinatal Medicine, an extraordinary, exceptional faculty that we are fortunate to have. Next slide, please. Dr. Hema Divakar, I think, is synonymous with gestational diabetes, co-chair of the India Pregnancy, co-chair for India, the Pregnancy and NCD Committee of FIGO. She's the past president of FOGSI and heads the Divakar Hospital in Bangalore. But more than anything, Hema has been such an amazing voice for girls and women, and a great friend of Divas and personally mine. Next slide.
Thank you.
Dr. Anil Kapoor is the chairman of World Diabetes Foundation Denmark. Again, a great friend of Divas and personally myself, member of FIGO and co-chair of the Committee on Pregnancy and NCDs, vice president South Asia Initiative on Diabetes and Pregnancy, again, past president of the DIPSI group, has been on various committees, widely published, and again, a very, very forceful and big voice for linking NCDs and gestational diabetes and impressing upon everyone. Actually, Dr. Kapoor uses the term gestational diabetes is a communicable disease. And now in the presence of COVID, I think he's been prophetic and it's come true. Next slide, please. Next slide, please. Yeah. So just to show you the committee members that are there, and we are fortunate to have 3 of the members. This is the moderator, myself. I'm an endocrinologist based in Chennai. I head the diabetes and endocrine and women's health department at VHS Chennai. VHS is a trust hospital for low resource setting people. Shalini Jaggi and Anjali Bhatt are my co-moderators for this session. Next slide, please. So this is just about myself. I already mentioned. I just want to say I feel very fortunate because I've just been asked to come on the stream of IDF for their 2021 Congress and hope to help shape the agenda and bring in a lot about gestational diabetes and about preconception care. Next slide, please. So Shalini is from Delhi, consultant diabetology and diabetologist and director of the Life Care Diabetes Center in New Delhi. And again, a member of the RSSDI National and Joint Secretary of the Delhi chapter, very active in the DIPSI group, and someone who, one of the young people with a lot of passion for gestational diabetes work. Next slide, please. Anjali Bhatt is a consultant endocrinologist from Pune, very passionate about gestational diabetes, patient care research. She was with the Chalaram Institute before, where I know the kind of outreach work she's done. And she trained at CMC Vellore, which is one of the most prestigious places in India. So I really want to wholeheartedly welcome this whole team. And we, next slide, please. And Dr. Durga Damodaran is my associate at VHS, a consultant family physician diabetologist, works in with a lot of gestational diabetes area. She'll be doing something unique, which is at the end of our session, collate the most important points and call them the key takeaways, and will be presenting that to us. And next is none other than my friend Purvi Chawla from Mumbai, Director of Clinical Research at Veena Diabetes Center, and the leader metabolic and diabetic disorders at Piramal. Purvi is again very passionate about our work, and especially in the area of pregnancy and diabetes. And she will be coordinating the audience question and answer session today. Next slide, please. So with that, we are going to move on to Professor Moshe Hod and his keynote address. Welcome, Professor Hod.
Thank you. You have to allow me to share the screen.
Please take your time.
Okay, thank you for having me on this webinar. It's a great pleasure for me to take part in this all-Indian webinar on diabetes and pregnancy, and mainly be speaking about GDM as representing NCDs. And I would like to start first with introducing my Indian family that you see them on the right. And we kind of started our relations around about 9 years ago when we met in New York at the United Nations. And that was a meeting organized by WHO. And we are here pictured with Dr. Margaret Chan, the Director General of WHO, and with me, Anil Kapoor and Hema Divakar. And that was a very, very important meeting. That's why I use this slide very, very often, because that kind of was the first recognition of the mega organizations, the United Nations, WHO, that we are, and stating that we are facing a slow motion disaster. About that time, Margaret Chan published an editorial in the New England Journal of Medicine, and clearly declared, we are facing a slow motion disaster. And she delineated there is an increasing global crisis in NCDs. NCDs are associated with mortality, morbidity, and long-term disability. And 2 out of 3 deaths globally are attributed to NCDs. But the main take-home lesson that actually started at that time in September 2011, that NCDs are programmed and imprinted during pregnancy. And if you want to start and interrupt the vicious cycle of NCD programming and imprinting, you have to start during pregnancy. That's why diagnosis and management of all pregnancy complications, it's not only GDM, it's hypertension, hyperglycemia, obesity, any other pregnancy complication will produce at the end a future NCD. And I'll show you later in one slide how diabetes begets diabetes, or how pregnancy complication begets non-communicable disease. So yes, we have to diagnose and manage all pregnancy complications in utero. So that was the main lesson that was learned at that time. And since then, during the last 9 years, Hema, Anil, and myself, we are pushing this agenda as hard as we can, because pregnancy is a real window of opportunities. Have a look on the number of pregnancy complications. What do we mean in pregnancy complications and their maternal morbidity and fetal programming? We have globally every year about 135 million live births. Have a look on the complications on the right side. Maternal anemia, 55 million. Undernutrition, 26 million. Malaria, about 20 million. Obesity becoming a huge, huge burden on every community, not only in low-income countries, but in high-income countries as well, 42 million, and it's underestimated. As well as maternal hyperglycemia, it's really underestimated with only 21 million, but believe me, it's much, much more. Hypertensive disorder, about 10 million deliveries per year. And that's what I call the one slide presentation. And that's the main take-home message, because if you'll remember this slide, then you'll understand how diabetes begets diabetes, or how pregnancy complication begets an NCD, and how can we interrupt them. So how do we prevent NCD? How do we prevent the appearance of this Botero family and for 3 generations? So that's what we call in FIGO, in our committee, the life cycle approach, as pregnancy as the window of opportunity. We have 3 entry points. The first entry point will be during the preconceptional management. There, when we get our lady who is not pregnant yet, we have to identify whether she had already an NCD, whether she has diabetes, she has obesity, hypertension, cardiovascular disease, mental disease. And if yes, we have to prepare her for pregnancy. She can't just get pregnant without notice. We have to deal with it, and we have to prepare her for pregnancy. Second entry point is the first trimester. The first trimester is becoming now a crucial, maybe much more important than the rest of the pregnancy, because here we can predict and prevent most of pregnancy complications. We can predict here GDM, preeclampsia, premature labor, IUGR, fetal growth retardation, even IUFD, fetal death, because if we identify them later during the second and third trimester, the disease is already here, the complication is already here. So all we have to do, we can only treat it, manage, and follow up, because the abnormal uterine environment and programming and imprinting are already in full action. So it's there. Then we end up with a safe delivery. But now the vicious cycle continues. It won't stop here. We obstetricians, many of you are diabetologists, And that's in your, actually, we are passing the game now, the ball, to your battlefield, to your playground, but it's together. It's a game that we have to play together, obstetricians and diabetologists together. Because have a look what happens in the postpartum. If we just follow here the offspring's health, it will go through neonatal insulin resistance, childhood obesity, early metabolic syndrome, PCOS. And I noticed that your next webinar is with Mark Molich on PCOS and other endocrine complication. And I was actually a fellow at Northwestern University when the room next to me was Mark Molich. And I won't tell you how many years it is before. It was in the late 80s, so quite a time. Then adulthood obesity, and then of course a full blown out NCD. For the mother, it's straightforward, maternal health, and we already have enough data. In a year, in up to 5 years, 50 to 80% of GDM mothers will have a full blown up diabetes, type 2 diabetes. Obesity, a hypertensive mother will have hypertension or chronic or cardiac vascular disease, mental disease. So this is the vicious cycle. How do we interrupt it? How do we cut it? It has to be an intervention in one of these 3 action sites. For me, the most important one will be now at the first trimester. And we are looking for more and more new technologies to come up with new ideas to predict pregnancy complication. Because if we will prevent a pregnancy complication, then we will prevent programming and imprinting for these 2 offspring. And then we will prevent, of course, the mother from continue with her future NCD. So this is our endpoint. So these are the 3 entry points, as you see, 1, 2, and 3. And this is new. This is the concept that we established during the last, I would say, 3-4 years, together with Emma, Anil, and our pregnancy and NCD committee. Now we are living in the very, very fortunate and exciting era. I called it the modern FMFM era, because before we almost didn't have anything. We have prenatal diagnostic tests, biochemistry, ultrasound only emerged, fetal heart rate monitoring. But have a look what we have now. Biochemistry is still there. Have a look on NIPT, what we call now cell-free DNA. We can look for the fetal DNA in maternal blood. And again, it was only developed about 5 years ago. It's already old now because we have more and more data now on bioinformatics, big data, and artificial intelligence. We have more and more whole genome sequencing, microbiome, metabolomics, small RNA, and proteomics. So it gives us a huge hand in predicting and then following with preventing pregnancy complications. We also are very fortunate to have the outcome of 3 mega studies. We didn't have it before. The first one was the HAPO study, GDM, 25,000 pregnancies that were followed up during the HAPO study. And we have robust data, big data, that we can come up now with conclusions about GDM, how to diagnose GDM. Then we have the ASPRE study, 27,000 subjects that can predict hypertension in pregnancy, preeclampsia, and we can even have the proof for prevention of preeclampsia. 80 to 90% of preeclampsia now can be prevented by administering aspirin before the 14th week of pregnancy. And lately, we have the HAPO follow-up study with about 10,000 cohort from the previous HAPO study, follow-up of about 10 years, and we have clear evidence what happens to the mother and the offspring after 10 years. Why FIGO? I'll go through it very, very quickly. FIGO is the mega organizations that brings together professional societies of OB/GYN, like for you diabetologists is IDF. This is our IDF, International Diabetes Federation. This is FIGO, in the International Federation of Gynecology and Obstetrics. Have a look on the discrepancy between the right side here and the left side here. On the right side, and in the center, we have our 135 million live births per year. On the right side, we have low and middle income countries. Have a look on the numbers here. India, of course, in the lead. There is no other country in the world that have a production of 30 to 40 million deliveries per year. India is unique, a mega country in deliveries and, of course, complication of pregnancy. But have a look on the rest of them, Afghanistan, Pakistan, Bangalore, and the rest of it. Altogether, coming up to 55 million deliveries. Africa, 30 million deliveries. China, 18. Brazil and Mexico, 15 million deliveries. So almost all deliveries globally are on the right side in the low and middle income countries, as well as the complications. So all the complications are, of course, here. Have a look what happens on the left side. USA, America, the big America, 5 million deliveries. Europe, 5 million deliveries. So these two huge continents have about 10 million deliveries. The rest of it, 125, are here. But have a look on the discrepancy. All the guidelines for the whole world are being produced here on the left side by these two continents. So can they be adapted as they are to the right side, to low and middle income countries? And the answer is, of course, no. And that's why FIGO comes, enters the game, and brings together all of us together, and we can change this game. We can adapt the guidelines that were started here, but to adapt them to the right side here, because we have the power to know and to have the unmet needs, to represent the unmet needs of the low-income countries, the low and the middle-income countries. So that's why the FIGO Pregnancy and NCD Committee was established. It came to light in 2018 when we merged the Hyperglycemia in Pregnancy Working Group and Nutrition Working Group. Emma, Anil, and myself, we were leading the Hyperglycemia in Pregnancy Working Group for 3 years before, and Mark Hanson was leading the working group on nutrition. So we merged these two committees in order to come up with recommendations that will finally bring to an end the dispute about the management, diagnosis and management of GDM, with these 3 entry points in highlighted. Like I said before, pre-pregnancy, pregnancy, and postpartum. This is the NCD committee. And fortunately, this picture was taken exactly 1 year before COVID-19 hit us, the pandemic. It was during the pregnancy deep Congress in Florence. It was even less than 1 year ago. And I'm very fortunate to have here with me Anil, Hema, myself, and the rest of the group. Many faces you'll recognize here. Those are the leading, I would say, global authorities on pregnancy and pregnancy complications. Have a look what we produced during our lifetime for this pregnancy and NCD committee. We produced the hyperglycemia in pregnancy guideline, Anil, Hema, and myself, HAP1 and HAP2. That's hypertension in pregnancy, Leona Poon. Leona already presented the HAP1 guidelines here in India, and we are coming very soon with HAP2, diagnosis and management. So hyperglycemia in pregnancy will be done. We came out with postpartum guidelines, which are extremely important to us in order to predict and prevent later type 2 diabetes. Came out last year. We are coming out now with the nutrition guidelines. We call it PONI, Pregnancy, Obesity, and Nutrition Initiative, led by Mark Hanson and Fionnuala McAuliffe. We'll be coming very soon with fetal growth guidelines, led by Nir Malamed from Toronto, Canada, and Ahmed Bashat from Baltimore, USA. And I'm very hopeful that we'll be able to bring the health economics initiative initiative to a happy end. And Anil Kapoor is the leader of this group, and I'm not familiar with another person who has such a vast knowledge about health economics and their use in pregnancy complications. So hopefully we'll be there. The FIGO GDM initiative started in January 2015. It ended up in October 15 with the publication of the International FIGO guidelines on GDM management. It was published here. You can get it from our website. We produced infographics translated into every possible language that we can. And the main take-home message for you as well, that we recommend universal testing and a one-step procedure. It still has to be, I would say, absorbed mainly in the United States. So in January 19, 1.5 years ago, we came up with an editorial, Anil, David McIntyre, and myself, in the American Journal of Obstetrics and Gynecology, the main US journal, and of course, where we brought the evidence and support of the IADPHG criteria, the FIGO criteria. At the beginning, most of the SMFM, ACOG group were with us on this paper. But for political reasons, and I don't want to start it again, they kind of decided to back off. Then Vincenzo Berghella still resisted, and he came with the one-step approach diagnosis a few days afterwards in the American Journal as well. So we ended up this dispute in November 18, when we had our global declaration in Rio de Janeiro, the postgraduate course when we had the SMFM Congress in Las Vegas last year as well, and the consensus commentary in AJOG. And lately, we came up with an editorial that was led by Anil towards a global consensus or GDM. We finally see a light at the end of the tunnel. That's what we think. Hopefully, our peers from America will join us because the evidence is here. And this is the roadmap. And I actually declared here, I don't want to hear any more debate about diagnosis and management because FIGO is representing all of us. So we had a very, very low roadmap with this HIP declaration, the hyperglycemia declaration, that actually started in India, in Sri Lanka, with the SciDip Colombo declaration. And then we went to every possible continent and we signed the agreement there. And actually then we finalized in Bangalore, in India, in May 2018, and the final declaration, of course, in Rio de Janeiro, October 2018. So I don't want to discuss any more diagnosis. It's done for me. We came up with the postpartum, and that's I'm mentioning because it's very, very important. Because if you diagnose GDM, you actually diagnose, you predict type 2 diabetes. So why are we looking for markers that are going to cost us huge amount of money post-pregnancy when you ladies, 50% of the population that had a pregnancy and had a GDM, the pregnancy is a physiologic marker. So if you had GDM, this is it. You don't need any other test. You don't need any other prediction. Just do it. Enter any program. And I'm sure that you have in India many, many programs how to deal with post-GDM. And it will be there. We started the Pregnancy and Obesity Nutrition Initiative led by Mark Hanson, Fionnuala McAuliffe, and I joined with Ronald Ma and myself. Those are the guidelines on nutrition that came up in October 15, 5 years ago. Think nutrition first, but this is the next one. This is the next step. We'll be coming up either in September or in October with the next FIGO obesity guideline that we call PONI, Prevention of NCDs in the Preconception, a FIGO position paper, and it will be out. Now, as we are going to deal later with few management tools, I couldn't give the whole lecture on GDM, so I picked something very, very new. And this is attributed to Kavita Kapoor. Kavita is a leading person in nutrition and in pregnancy nutrition and GDM nutrition. And that's a paper that Kavita, Anil, and myself are coming out. It will be published probably either in September or October in the Annals Nutrition and Metabolism. And we call it Nutrition Management of GDM. It's a landmark paper. And I recommend everybody in the business, in the GDM business, to get it. And as soon as we'll have it in PDF, I'm quite sure that we'll be able to share it with you. So I just want to go with you through few very, very mild guidelines that were there. Globally, most widely used guideline for gestational weight gain is the Institute of Medicine, IOM. And Dr. Sriram outlined few questions later that deals with IOM. And it's here. The IOM guideline does not provide any specific recommendation for GDM. The FIGO guideline states that normal weight and underweight women, the IOM guideline apply, and the rest of it. I don't want to go through all of it. We'll discuss it when we'll get to the questions that were produced by Dr. Sriram. There is the recommendation and weight gain. We'll deal with it as well later. Those are the FIGO guidelines. That's the only table that I took from our guidelines that deals with pregnancy, obesity, and nutrition initiative that have about 10 key points to be addressed there during the preconceptional consultation. And they are extremely important. I'll share it with Dr. Sriram, and I'm quite sure that she'll be able to share it with you. The PONI declaration, I mentioned it here, was actually launched here. At the beginning of the year, Mark Hanson and Hema Divakar actually launched it here in India during the Artist Here presentation, and I'm sure that Hema will mention it a bit later. Very, very briefly to mention the pharmacological management, again, taken from the guidelines, because Dr. Sriram addressed it later in her questions. Pharmacological management, if lifestyle modification alone fails to achieve glucose control, metformin, glyburide, or insulin should be considered as safe and effective treatment of GDM. Here is the recommendation for glucose monitoring in women with GDM. Again, I'll share it with you. Pharmacological treatment, insulin, glyburide, and metformin, all oral hypoglycemic agents are safe. Lately, and you asked me specifically, we'll address it later about the MIG study and the other metformin studies. Metformin is kind of preferred now to glyburide. My personal experience, and I'll be extremely happy to have you share your experience with me, it won't work on my patients. So I usually start metformin because I recommended it, but then I'll go back to glyburide. Glyburide is more effective, but I would be very, very glad to have you Indian experts to give me your input on it. Insulin treatment, we provided data that insulin analogs are safe and very, very efficient in pregnancy, and there is enough data, and the strength of our core recommendations is very, very strong. I'll kind of finish with inviting you all to join us, and hopefully it will take place. I really pray that it will take place because I want to see my friends, all my friends from India, all my friends from all over the world, because I haven't seen him for the last 7 months. And it's very rare for me not to meet my friends all over. So hopefully in April 21, we'll meet, all of us will meet in Saloniki, Greece. And I'll finish with what I call breaking news. That's something that I share with you for the first time. Hema and Anil don't know about it as well yet. So I'll be very glad to have their input about it. And that's coming from COVID. COVID pandemic forced us to make a change. Many of our patients refuse to come to the clinics, to the hospitals, to meet their caregivers. So we are now trying to come out with a solution to move our office to home. So I called it New Approach to Pregnancy Management from Office to Home. And as you already know what I'm preaching for the first trimester and the second trimester and the third one. So let's have a look. We want to end up in safe delivery. So we are starting here a project in Israel. I'm working with a new initiative. We called it Sabar Preg Care. We need an EMR, a very basic EMR, electronic medical records that actually will capture everything inside. And we can work with any care provider, HMO, hospital, community, private obstetrician, private patient, with whoever you want. Then first trimester, we'll have a call center here and we'll try to get as many as possible tests that can be done outside. So early pregnancy or first trimester, we'll want a DNA panel for both parents. Then of course, for the mother, cell-free DNA, laboratory, NCD triage to see whether she already has an NCD. So then she's considered a high-risk pregnancy and maybe start with her new procedures, NIPT at about 10 weeks, and then outsourcing that we can't do it at home, of course, nuchal translucency at 11 weeks, chorionic villi sapling 11 and 13 weeks if she'll need it, anomaly screening at about 13 to 15 weeks, and amniocentesis if she'll need it. So that's the first trimester. During the second and third trimester, we want mainly to kick off our protocol initiative with a home NST, fetal heart rate monitoring at contractions. That will be the kickoff. And we already have many, many tools that we can deal with it. So we can do NST, we can do fetal ultrasound, we can do continuous glucose monitoring non-invasively, and I show you very briefly about it, vital sign and laboratory, of course. Then it will, of course, follow with sonography, vital sign, glucose, continuous monitoring or diagnosis, and outsourcing, OGTT, anomaly screen, and fetal growth. And here are the tools that we already have in our hands. So that we already have. So all these are already available. All of them are available. That's the first trimester. But in the second trimester, we have many startups now that coming with more and more solutions that can be used at home. So the fetal monitoring system are all of them here. I'll be working with one of them, probably a company called Heramed that this is the device. This is the whole fetal monitor. It sits here. You give it to your patient, and she can monitor her fetal heart rate and contractions. It comes out from this box, and that's the device. This is the whole device. Then, of course, there is a new sonography tool that can be connected to your smartphone, and you can do very basic sonography on your patient. And hopefully, in the future, we can do much more. We can maybe even measure cervical length, but I'm sure that we'll be able to measure amniotic fluid index. We'll be able to use it for fetal movements. With vital signs, they're already here. These tools cost few bucks, very, very cheap. This is a new one, an innovation that Hema and Anil will be part of it. This is a continuous glucose monitoring tool, non-invasive. It's kind of a Fitbit. It's a watch that sits on your wrist, and continuously reads your glucose values. We are starting in September a huge study on prediction of GDM. We'll give it to about 300 patients, pregnant ladies at the 10th week of pregnancy. They'll wear it until 24 to 28 weeks of pregnancy. Then we'll do an OGTT, and then we'll divide the groups to GDM positive, GDM negative. And then we'll have huge data, big data, starting from 10 weeks. Hopefully, we'll be able to construct an algorithm that will predict GDM. This is a colposcopy tool, again, later, not to be used now, but at a later stage. Home blood pressure, we already have it. And there is a new tool for home OGTT. So this is the future. And of course, the outsourcing. I'll be very glad to discuss it with my friends in India. And if it will be of interest, then we'll bring the system to India as well. Thank you very much.
Thank you so much, Professor Hod. I think you have already answered a lot of questions that, and particularly, I think, stress the importance of that pregnancy is a window to future chronic disease. And it's actually like a pregnancy is a stress test. And anyone who has pregnancy complications is actually someone who should be watched very closely for future chronic disease. So really grateful for that great talk. We move straight into our Meet the Professor session. If we can go to the next slide, please. Next slide, yeah. Thank you so much. So, Shalini, you want to begin with?
Yes, Professor Hod, that was just an excellent session, I must say. And, you know, the kind of technologies that we are using in this era, I think this is just the time, just the right time to adapt to technology so that, you know, the clinic can actually be taken home to deliver the best of care to all our patients. With that remark, I would like to pick up my first question, which is based on something that you showed me in the slides also, which is based on the weight gain. Weight gain in pregnancy has been an issue that all of us do face amongst our pregnant patients, because the gray area here is we just have the Institute of Medicine guidelines, which you rightly said in the publication have a lot of limitations. So what are the weight gain recommendations? How do we go about recommending weight gain to our patients, you know, because it's going to vary from each patient to each patient. So simply that BMI based weight gain guideline that the IOM gives, is that sufficient? Or are there other indicators? Where are the fault lines? So I just want to talk to you about all this weight gain scenario. How do we go about deciding what is the ideal weight gain for the patient sitting in front of me?
Okay, thank you. Great question. That's why I actually brought the IOM slide in my presentation from the Kavita Kapoor paper that will be published very, very soon. And I really recommend you all to get it. We'll be able to share it with you. I'm sure that Anil and Kavita will send it to every demand. So basically what we recommend is to stick to the BMI. And the normal BMI will be a weight gain of between 11 and 15 kilograms for the whole pregnancy. Is it right? I am not sure. That's why we specifically said that IOM is a guideline, but it has to be adapted to the situation and to the country. And here I'll be very grateful to Hema and Anil and to you all, to the all panelists, to address the issue in India, because that's something that I'm less familiar with it. And I will be very glad to hear how do you deal with it in India, because you have different, I would say, different dietary attitudes, different weight gains. So it will be very, very important to have it here. On the other hand, we know the pandemic of obesity. Obesity is a huge pandemic. It's not only COVID. It's bad as COVID. So we have to deal with obesity, and now we know, and we'll be coming with this obesity guideline. We have to get our patients ready for pregnancy. And if they are obese, to try and bring them as low as we can towards pregnancy. And I'm lately becoming more and more interested in the ketogenic diet. The ketogenic diet is a very, very interesting tool. If DEEP will take place, I'll bring two of the leaders of ketogenic diet, and we'll have a huge debate about ketogenic diet and pregnancy. For pre-pregnancy, there is no doubt about it. But can we use it in pregnancy? I'm still hesitating, and I need to be convinced, and I'll be very glad to have your opinions about it.
Yeah, because conventional teaching has been pregnancy is not the time for diets, and pregnancy is not the time to actually lose weight. So then the dilemma about, you know, the BMIs that we Indian women have are very different from the BMIs that the Caucasians have. So having just a single guideline based on the BMI with complete disregard to our ethnic predisposition, to all the other dietary factors, I think we definitely need something which is more our ethnic based guideline to actually talk about a weight gain parameter. And this is where I would like to bring in Dr. Hema or Dr. Kapoor for their comments.
Before Anilji makes his comment, because specifically alluding to the paper that Kavita ji, Anil and Moshe have put up, which he'll have more specific inputs to give. Broadly from the OBGYN perspective, the clinician's perspective, I must place on records that only in the last 5 years, we have sensitized all the OBGYNs to actually even record the BMI. Because, you know, even this thought process was not there. It was to just be the weight, BP, and then that's it. So to pay attention to recording it and, you know, tracking it pre-pregnancy and in pregnancy, that has been, you know, still it's not implemented to the extent that we want, but it is there somewhere on the papers. The second thing, Shalini, is that the concept that restricted weight gain is something that we have to pay attention to, especially in BDM pregnancies and pregnancy with obesity. It's also a new concept which is now being drilled in, not only to the peer group, but also to the community as well. Because they are totally tensed up if we say that you restrict your weight gain, because they always believe that they must jump weights at every visit that they have to come. The third thing I want to place on record is accuracy in checking the weight and also longitudinal follow-up, especially in the large public institute where the volume is so much. They will check the weight anyways. Okay, who is recording them? Which corner of the paper are they recording? Who is the next person who sees them in the next visit? Is she paying attention to the weight back and forth? It's something that really needs to be paid attention to, because that kind of tracking, we have in reality not seen it happening in the public sector practice for sure, and many places in the private sector too, because it is like, you know, and I also ran kind of a documentation that they will do, but not very significantly. So these are my thoughts on, you know, how much more we need to be doing in this vertical related to the weight issues in pregnancy, though broadly we say 10 to 12 kilograms through the pregnancy for a normal pregnancy, restricted 6 to 8 kilograms in a GDM, so on and so forth. But that is like very broad. But if Anilji and the new paper is bringing out something, then it will be a huge advocacy campaign that we need to do to see to it the gap between what they have said and what we actually do in practice should be bridged as strongly as possible.
Shalini, may I add something?
Yes, ma'am, sure.
Just wanted to say that to draw a parallel to the growth charts, we see children who are brought to us for growth retardation, and there is no growth chart. So we don't have a framework. So to take Hema's point, can we have like a graph for every patient and actually have an area which is supposed to be normal weight gain? And if we only plot the graph each time, we know if she's you know, staying on the same trajectory or going up or down. Will that help?
Yeah, I think so. It's a simple Indian innovation, Moshe. not such a innovative environment, which was so exciting at your previous conference that we were exposed to at Tel Aviv. But, you know, simple, small steps like this, I think will start making a bigger difference. That's what I feel. What do you say?
The comment.
Yeah. Go ahead, Anil. Yeah, go ahead.
Yeah, what we did in the paper is basically we looked at the global guidelines across different organizations that have guidelines on pregnancy. And it is very strange that very few guidelines even talk about what is an ideal weight gain during pregnancy. And so there's a lot of confusion around it. And so it's very difficult to specify one specific kind of guideline which would be applicable to everyone. Therefore, we will have to develop something on our own. But one of the suggestions is that what Usha ji said about monitoring the weight gain during pregnancy on a chart, but also looking at the fetal growth. There are fetal growth charts available, and as long as the fetal growth charts are adequate, we need to ensure that women are not gaining excess weight, and that has to be linked to the fetal growth. So if the fetal growth is not adequate, the women has to put on more weight. If she is not, if the fetal growth is appropriate or higher, then she has to cut down. And that is what we would have to find out. And the concept of using a fetal growth chart as a mechanism to monitor weight gain and caloric intake of the women is something that needs to be discussed more widely and perhaps researched.
I want to add to it. That's why we are coming in about 2 months with fetal growth guidelines under our committee. So Anil is absolutely right. It has to be tailored to the fetal growth. And that's why we are coming with these guidelines. We are coming with growth chart that will be easily adapted to every region. And you'll have an answer how to manage and follow up the mother, but also the fetal growth according to the chart. Be patient, in 2 months we'll have it out.
May I ask a question?
Yeah, please go ahead, Anjali.
Yeah. So I just wanted to know from the expert panelist, is there a relationship between the pre-pregnancy weight or BMI of a lady and the weight that she gains during the pregnancy? Is it so clear as to obese women gain more weight and non-obese women gain less weight? I mean, what we recommend is different, but what is the observation is what I wanted to know.
It is generally true that women who are overweight are more likely to gain weight during pregnancy compared to women, because it's also about their own concept of their body image. And therefore, a woman who is being slim and trim before pregnancy is more likely to be much more conscious of her body weight and her gain in weight compared to a woman who has been generally on the higher side. And so that's actually quite a true issue.
Sure.
Again, as Anilji said, we need a lot more data on this, and we don't have access to the pre-pregnancy weight per se, except that they verbally tell us that, you know, before the pregnancy, my weight was so and so, and then if we care to, then we have to document that, but that's not yet translated really into practice.
I agree.
Now, we do have a comment from Dr. Uma Ram where she says, in addition, given the South Asian BMI cutoffs, we don't really know if the IOM weight guidance can be used as it is for our South Asian BMIs, you know, for our groups. So I think, I feel there's...
She's absolutely right on that.
Yes. So I think we definitely need some kind of a guidance, some kind of data collation in our South Asian groups. I think from all parts of India, if we can start collecting that data, collate that and come out with something which is specific to our population to get more clarity and to recommend that.
Okay, Shalini, we have to move on.
Yes, yes.
I think we're running late.
So next
Can I make one suggestion on that?
Yeah.
If we all start recording the BMI, pre-pregnancy BMI and weight gain, and then categorize it based on the starting BMI and try to plot a national graph of what women in India normally weigh, if they start with a normal weight, underweight and overweight, then we might be able to do something about it. But until and unless we have the data, it will be very difficult.
I think that is something that we can all start doing, since we see a lot of GTM in our practices. I think this is something that all of us can take together as a common project and then come out with data and collate and see how we're faring. So I think this discussion can go on. So we'll move on to the next slide. Can we have the next slide, please? Yeah.
So I think Professor Hod has addressed these, so you can move to the next question. Keep moving. Next slide, please.
Next.
Yeah, this one.
Yeah. Okay. So now, to make things a little more relevant, going on the other track, which relates to the treatment part, I have a case here. And Dr. Hema, I would like your opinion first on this, and then we can have the experts coming in. This is something that we see in our practices. A PCOS woman getting pregnant at 29 years, she's already on metformin, and now she's come to you at say 7 weeks of pregnancy. And the first thing that is usually done in the ANC clinic is to just ask her to go for an HbA1c assessment and just a fasting glucose. So do you think these two are just sufficient to actually look at her glycemic status, or are we going to miss out something? And then the second part of my question here would be, she is already on metformin, she is PCOS. So now we have a lot of studies coming in. We've had the PregMet and then we had the PedMet data. So what is the time, what is the dictum for metformin that needs to be followed? Do you need to stop metformin immediately as she conceives? Do you continue it till the end of first trimester, or do you continue it throughout pregnancy?
Okay, Shalini, this is again a great question, because this is a very common scenario in our practice for sure. So I would go one step further to say, with my beloved friends and colleagues here, Professor Mojay Hood and Anil, who always been sensitizing us on the life course approach and how we ought to have taken care of this PCOS if she would have been presented to us before pregnancy. Perhaps her weight, her glycemic status, and several other things have to be assessed then, so that we would already know in what state of dysglycemia or otherwise she's entering the pregnancy. That's point number one. So all our infertility colleagues also, we tell them that there is an excess. So please be, cautious about that, and do check their glycemic status prior to entering into the pregnancy. So having said that, if we strictly follow the Indian guidelines, the FIGO guidelines, the Government of India, FOXI and DIPSI guidelines, the first test that we do is the single step test with the 75-gram non-fasting at around 10 to 12 weeks of pregnancy. So if we stick to that guideline, we would have anyway done that test with challenging her the known amount of glucose at the said gestational period. Most of them who are on the PCOS treatment with metformin, or she may have also taken assisted reproductive technologies to conceive, the common practice is to continue the metformin at least until 12 weeks of pregnancy. So in the first place, you said that in the antenatal clinics, routinely the HbA1c and the fasting blood sugars will be done. That's really not a routine scenario as per the recommendations. Having said that, even if the HbA1c was done, if her very first, reading shows that it is haywire, that means we missed the opportunity of checking her before she embarked into a pregnancy with an optimal or an appropriate HbA1c. That's what we would recognize. And only doing the fasting is, perhaps not going to pick up several cases of hyperglycemia in pregnancy. So that's not the only thing that we will stick to. So when you say whether it's truly reflective, these are, my thoughts on that. And about stopping the metformin after 12 weeks. Okay. And just presuming, because she is of an Indian ethnic origin, she has greater chances of developing hyperglycemia in pregnancy. Okay, so let's continue the metformin on and on till she delivers, so that she may have a lesser chances for GDM. That's a clear no-no, because there is no literature support, no evidence for just blindly continuing this on a presumption that it would act as a preventive precaution. So as per PCOS or the infertility specialist advice, till 12 weeks we'll give. We will take a stop. We would have done the challenge test. Then we'll see how it goes. Then if the sugars are haywire, then the MNT and whatever other course has to follow would follow. So that is how it is.
Ma'am, EAST 2019, there was this PedMet study, which was actually a follow-up data of PregMet, and few more studies that had discussed and shown that ladies who were given metformin throughout pregnancy, the babies born to them when they were followed up at 4 years, and then we have some later on data also, these babies had higher head circumferences, their BMIs were more, they had an increased propensity. So do you think, and also we know that with metformin, there's slight increase in prematurity rates that has been seen. So your comments on...
Shalini, for bringing this point for discussion, thanks so much, because yes, this long-term implications of giving metformin between 12 and 20 weeks. This is the data about that, and therefore in the Indian Government of India guidelines, in the first version of the guidelines in 2014, we said that we go from medical nutritional therapy straight to insulin. Metformin was not even included.
Right.
Then with the FIGO guidelines coming in, metformin, glyburide, etc., then in the 2018 amendments, oral hypoglycemic, as in the metformin, got included, but with a special clause that 12 weeks and beyond 20 weeks, it's okay. But 12 to 20 weeks, there is no strong data, and the long-term implications have to be kept in mind precisely because of the study that you've mentioned. So that zone, not that many clinicians, especially in the OBGYN sector, are aware of this, because they only know that now the metformin is included in the amended guidelines. So they're all, very joyous that, okay, can, step up to metformin rather than the insulin. So that's the mindset. So we are again on a rework and sensitization, the 12 to 20 weeks, because of this precise reason that we should be refraining from
this is something
giving
as
the
diabetologists we always face. The moment I stop metformin in that particular time, I get a call that no, she's PCOS, why did you stop metformin? So then I have to tell them that, see, this is the data. I know. They're like, no, our guidelines recommend metformin has to be continued. So I think that disconnect.
No, our guidelines, the GOI guidelines, Nikhil Tandon ji was there and the whole endocrine team was there face to face, and we discussed this, and we have, moving further, we promised to check out and try and give some data between 12 and 20 weeks. But as of now, even in the Indian guidelines, though metformin has been included from the year 2018, it's only up to 12 weeks. And then, okay, because if the first test is normal, anyway, you would repeat the test at 20 weeks.
Absolutely.
At that time, if it's abnormal, yes, MNT. That fails, then metformin is okay. Then if that doesn't control, then insulin anyway you will add. So from then onwards, the early pickups, it's a zone where you have to pay attention doubly to the facts that you have just mentioned, and we refrain from giving it.
Right. Thank you so much. Do we move on to the next question? Do we have any comments coming in from any of our panelists here?
Next slide, Shalini. We're running very late.
Yeah, next slide, please. So, Dr. Kapoor, this brings you in. The targets for glucose control, are they still high? Because the CGMS findings have very clearly shown that the normal healthy pregnant women, the glucose levels are much lower, the normal levels. So the targets that we set for our patients for control, are they still too high? Do you think we need to lower them?
In my opinion, I think they are currently okay. It of course has to be then considered in view of the particular clinical case. If the woman has high risk factors, previous history of GDM, or is obese or stuff like that, then we need to moderate these targets in a way that make it more applicable to her. But I think on a general principle basis, I think the current targets are pretty fine, because anyway, most of these women have mild GDM, and it is controlling the fasting blood sugar is often a challenge, and bringing it down to below 90 is going to be a tough game. It only creates further stress for women when they are not able to achieve those low targets, and might make it even more difficult to achieve the target. So I think the current targets that are there of 90 and 120 are perfectly fine. But
when Moshe brings in the wristband and we start collecting a large amount of continuous data,
those are different. Those are different issues, Hema. But in general, for a mass, practice, I think those targets are perfectly fine.
Yes.
And then it has to be modified in the view of a certain clinical situation. I think women with higher risk, one has to be a little more tighter with the targets. That's my personal viewpoint.
Can I comment? I absolutely agree with Anil. We have the numbers that we actually have now, less than 92 or 90, are based on the HAPO study. And that's the weakness of the HAPO study, because HAPO provided data from 24 weeks and on. We don't have a mega study that dealt with normal values of glucose during the first trimester of pregnancy. So we don't have the data. We can't base it on anything. That's why as soon as we'll have the continuous glucose monitoring system working for us. And I really hope that this wrist watch will give us the answer. Then by collecting huge numbers, big data on first trimester, early second trimester, we'll learn much more. And I think that then we can come up with more, I would say, evidence-based solutions. And
I would also add one more aspect to it. If the woman has been diagnosed to be hyperglycemic earlier on in the first trimester, I think we have to be much more stricter. But if it is the classical GDM type, then I don't think we need to get too much into a very high level of control. But if it is diagnosed earlier, this is likely to impact, and also there's other risk factors that are associated. So it has to be seen in a clinical context. These are general guidelines that we must adhere to, but in a given case, we need to modify them based on the clinical judgment.
Absolutely. I'll hand over to Dr. Usha to take it forward. We're getting late. I think we.
Thank you, Shalini. Next slide, please. Next slide. So back to Professor Hod. This is a 30-year-old lady, BMI 29, second pregnancy, 7 weeks pregnant. She had gestational diabetes during her first pregnancy. She was treated with medical nutrition therapy because I think this is from the COVID perspective. Should we now ask her to undergo testing or just assume she has GDM, start with self-monitoring in medical nutrition therapy, or do we have to actually do the test and reclassify her? And how long should we wait before retesting her formally?
Okay, again, that's a great question for the COVID time. And I'll divide it to COVID time and no COVID time, because that is crucial. So this lady is high risk for GDM. She has in a history GDM, and she has a BMI of 29, which means that she is on the obese side of pregnancy. So should she go undergo testing now or presume she has GDM? She has to undergo testing if it's feasible. So if it's feasible, she must have a GDM testing. So if she can travel to the clinic, I'd recommend to have either a fasting glucose or an OGTT. And you are very good in India with your diagnostic test that was developed in Chennai by Dr. Sheshaya, and you can do your fasting and your 2 hours test. So if that fasting will be above 92, she is diabetic for me. But is that 92 is evidence-based? The answer is no, because 92 comes from HAPO, and HAPO didn't have any data, didn't supply any data for the first trimester of pregnancy. If she can't travel to the clinic and she can't have a GDA, she can't have a test, I will go for the strict regime. I will give her, she's for me a GDM patient, because I'll have much more to lose if I won't treat her. So I'll just design her as a GDM patient, and I'll have her on a diet, and I'll try to get her a glucometer and see what's her glycemic profile. So that's exactly what I'll do here. And that's the COVID time. Now I am evaluating a British company that is proposing to do a home test in OGTT at home. I showed you the slide, and it will be a very simple test. The test will be shipped to your home, and then the rest will be done over the smartphone. So I don't have any doubt that in the near future, there will be solutions that can be managed at home. And I think that will be extremely interesting for India. And I know the stories from India that a lady has to travel for 2-3 hours in the morning, fasting until she gets to the clinic. And then only then she can do the OGTT. And that's why you don't have the fasting test in the Indian recommendations. So if she can do it at home, I think it will be a huge relief for you. So I hope that very shortly we'll have a solution for you. And how long we wait before retesting? 24 to 28 weeks, exactly as we do now. So if she is negative right now in first trimester, then I'll do retesting at 24 to 28 weeks. And again, we'll go to the Indian procedure. You have a great diagnostic test.
Thank you so much. And I just wanted to say that we have just submitted a paper where we have recommended something called as, I shared this with Hema, it's called Flexi GTT, Flexible GTT, where we are giving the women the 75-gram glucose packet. So they drink it at home, and 2 hours later, they're doing a finger stick glucose and then taking a picture of the reading on their cell phone and sending it to us. And this can also be done either at home, or it can be done in the doctor's office, or a frontline health worker can do it for the patient. And this is something that we are going to start testing. Hema and I just had a discussion about this a week ago, and I'm so grateful that you brought this up. So we'll try a cheaper version, and hopefully the company will come out with a more a professional version.
Usha, may I add, I think we don't have to wait for all this. I think in these times, it is very important that if in the FIGO guideline, we accept a glucometer-based reading,
Yeah.
why should we not accept it in these tough times to have this? And I think if women can do home pregnancy test, why not a home GTT?
Absolutely, and this can also be applied to postpartum, because what was one of the real reason why we thought of this was for the postpartum period, because the new guidelines from UK, Canada, and Australia had talked about waiting it out during the pandemic, for the pandemic to abate before doing postpartum testing. And our view was, even as is, they're not coming back for testing. And if we tell them you don't have to come back till COVID goes away, it'll be the next pregnancy when they show up. It'll be an out of sight, out of mind kind of a situation. So we thought we'll do this home thing for the postpartum period, and then said if it's good for postpartum, it's good for pregnancy as well. So try this out.
So when people are having oximeters at home, and during pregnancy being such a high risk area, advising a glucometer to be available during pregnancy is not such a big thing, especially if it can be afforded. Of course, we have the issue around the low income group that may not be able to afford it, but then we can use the ASHA workers or somebody else to be able to.
Thank you so much, Dr. Professor Hart, for that answer. Next slide, please. So this is to Dr. Kapoor. For women who have numbers that are clearly normal, no GDM, should we just reassure them, or actually give them some nutritional advice to prevent GDM? Is this a good way to prevent GDM? And what other strategies have worked for prevention? Meaning the ones whom we tell, good news, you don't have gestational diabetes, you're home free. Should we do it that way, or actually put them also on a proper diet?
Ushaji, I have always believed that pregnancy is an immensely teachable moment. And if we can use the fact that the woman was tested and was found normal, we should use that opportunity to educate her about what is healthy eating, what is good exercise during pregnancy, and also post-pregnancy. We should never miss the opportunity of testing during pregnancy and letting women say you are scot-free and everything is hunky-dory. I think it is a huge opportunity to create that knowledge base. And pregnancy is such an important moment where the entire family would be willing to stick to the advice, and it would probably become an inherent thing in the family if it is done properly. So I would say it doesn't even asked for a question whether we should provide nutritional advice and advice about exercising, I think that should be done to all women, irrespective of whether they test positive or no.
Professor Hart or Dr. Hema, you want to add to this?
No, in the interest of time, I think we agree with Anilji, because we have always been saying that lifestyle advice, no matter whichever bracket they belong to, pre-pregnancy, pregnancy, or beyond, it should. That's why we said think nutrition first, think nutrition and weight first. These are the kind of taglines we are bringing out just in order to sensitize that, yes, it's not only in saying, but doing what we are saying. So we must stick to that. And for everybody's information, in many of the apartment complexes now, one whole floor or one whole building, they have this common glucometers, pulse oximeter, everything is stored in one place. Everybody uses the same thing. So all, it's an Indian way of thinking how they can make it really cost effective. So a lot of things happening because of COVID. So it's a good thing. As Moshe said, we could have thought about this even COVID, but at least now we have begun to think about it. So that's great. I think we're expanding our, depth of percolation into the community, which is good.
Thank you, Hema. Next slide, please. So, which brings me to you. Are there non-pharmacologic options that can be considered for better pregnancy outcomes in women with GDM, in addition to insulin and OHAs, things like chromium and selenium and myoinositol?
Just prior to this, we had another, COVID, immunity, nutrition, and beyond, that kind of a seminar, because everybody has started talking about chromium, selenium, zinc, vitamin C, vitamin D, this, that, and the other. Again, because of the COVID thing, lot of these things, have got their repositioning and renewed role in many things, which we were not thinking about it before. But specifically to address this, the answer is, yes, there is something better than nothing. If that kind of a concept is there, you may give one supplement or the other in the hope that it will do something to the sugar, but your targets are your targets. Okay, no matter what you do or what you don't do, you cannot be complacent just because you've given a myoinositol or any, micronutrient that she's going to get better with that. Having said that, one important, large study that we've done in a randomized double-blind control, we did in 6 public centers for 6 months. We compelled them to follow the government guidelines to do the first trimester and the mid-trimester single-step testing, so that we understand the background prevalence of gestational diabetes in those setups. Then when we initiated this study of vitamin D3 versus vitamin D3 with myoinositol, really compared to the background, both the groups of women who have had this or the other, that is vitamin D3 is a common component in both, definitely the prevalence has declined very significantly. The interim reports are out, and a similar study done by All India Institute of Medical Sciences by Anup Mishra, again vitamin D deficient or insufficient population. He's also remarked that even pre-gestational diabetes is, it's one of the good target groups to get. So we don't have the final answer yet, because in the interest of the nexus between vitamin D and insulin resistance, in the keeping with the fact that most of our population are vitamin D insufficient or deficient, this may be one of the components spiced with myoinositol, which may be one of the food supplements that may abate the prevalence of gestational diabetes. But once again, I underscore and underline that we don't have strong evidence yet, and we cannot be complacent. Just because we have given this, we can switch off. Everything else that we need to do, we need to do. This may be also add on in some research settings as of now.
Thank you, Hema. And I think this...
Yeah, I would like to comment.
Please, sir.
This is a great and interesting topic. And even the mega pharma or mega industry are now entering the phase of studying more and more about it. Take, for example, Nestle. Nestle has a huge interest now in what we call nutritional manipulation of pregnancy complications. and that's actually chromium, selenium, and especially myo-inositol. It's a nutritional manipulation. So, for example, if you take a drug like acarbose and you treat type 2 patients with acarbose, and acarbose deals with alpha glucosidase inhibitor, and there is another enzyme that I always forget. But if you take an extract for a plant, and there are different plants that you can use them that deal with this specific enzyme, alpha glucosidase inhibitor, you can reduce glucose absorption from the gut by 20%. Not acarbose, but others. So there is huge interest now, and there is huge, I would say, emerging new topic that we are going to enter very soon, even cannabinoids. And I'm very now started to play with cannabinoids extracts. They have an ameliorating effect on glucose absorption from the gut. And if you reduce it by 20, 30%, it's not bad. So yes, it's a good point.
Thank you so much. Next slide, please. I think I'm going to hand over to Dr. Yes,
Usha, can I make one comment?
please.
When we talk of non-pharmacological things, we always forget about exercise. The level of exercise among Indian women and in men in general is extremely poor, and all obstetricians and gynecologists in India are quite afraid of recommending any exercise during pregnancy. I think this mindset has to change. Exercise is a very important aspect. All our nutritional deficiencies, vitamin D and this and that, are also linked to the fact that we are not exercising enough.
Yeah.
That's a great point. I'm going to hand over to Anjali Bhatt. And after this session, I think we'll go to the takeaways and audience interaction. And the audience, I'm sure, are waiting to answer a bunch of questions, ask a bunch of questions. Anjali?
Okay. Thank you, Usha ma'am, to hand me over the proceedings. Can we have the next slide? Yeah, so this is a question to Dr. Hott. There are two aspects of this slide. One is how important is the 1 hour postprandial value in women with diabetes? Is it something that is preferred to 2 hour, or is it same as 2 hours with just the difference in the target? And especially looking at it with newer very fast acting insulins, would you like to change from 1 hour to 2 hour or 2 hour to 1 hour? What is your thought on this? That is one. The second part is, in your practice, how do you decide between glyburide, metformin versus insulin? Here, I would like to slightly elaborate the question, saying that traditionally we take, in the classification of diabetes, we don't take GDM as a separate class. We don't include it into type 2 diabetes, because we just look at it as a window to type 2 diabetes, which is going to happen in future. But because the treatment is different, and the safety of medicines during pregnancy is different, we have classified it into a different category of diabetes. What I would like to ask or would like to know your opinion about is the choice of medicine different if it is GDM, that is pregnancy-induced diabetes, or if it is diabetes, which is first time detected during pregnancy and possibly might be present even before pregnancy? So would the treatment option change? Would you prefer OADs for pre-GDM and insulin for GDM? Or obviously the expectations are also different. In GDM, we want to prevent the weight gain. In pre-GDM or early diabetes, we want to prevent the complications occurring in congenital anomalies and the growth of the child. So would that be the deciding point for you to choose the treatment?
Okay, I'll just stick to what you have here on the slide, because otherwise I won't be able to answer everything. So question number one, I prefer the 1 hour to 2 hours because it gives me a more precise, I would say, playtime with insulin. And especially, as you actually very nicely said here, we have now the fast acting insulins. That's why we are very, very fortunate to have the precise, very, very fast insulins that can actually mimic the non-insulin resistant state and reduce the peaks after 1 hour. So yes, I will prefer the 1 hour, and yes, I will always try to use in the patients that I can't deal with medical nutritional therapy, because in most of my GDM patients, about 70% MNT will be fine, will be good. And I always have a look on their daily profile, which means fasting, pre-meal, and 1 hour. I prefer the 1 hour. So fasting, morning fasting for me is the most crucial number that I want to deal with. So if I'm getting lower than 90 for the morning fasting, I'm very, very happy. If postprandial for 1 hour is less than 140, and I even prefer 120, then that's my target. So yes, the answer to this one is fast-acting insulins and 1 hour. Glyburide, metformin, and insulin. In GDM, as I said, now we have more evidence that metformin is safer, is better, and more efficient. That's not what I encounter in my practice, in my own practice. For me, glyburide works better. And I am familiar with glyburide since 2000, since my good friend, my best friend, Oded Langer, published his New England Journal of Medicine paper on the safety of glyburide in pregnancy. That was 2000, exactly 20 years ago. And we didn't see any side effects. We didn't see any bad outcome in glyburide. So recently, during the last 3, 4, 5 years, we see more and more about metformin. So I do try it on my patients, and I don't see very good results. And I will be very glad to have my Indian colleagues to answer what's your opinion about it. So yes, I start with MNT. If MNT fails, I go to glyburide, and after a week glyburide fails, I go to insulin. But during the first trimester of pregnancy, I will prefer always to start insulin, because I am not sure yet that oral hypoglycemic agents, although they are used very frequently, as in your previous question about PCOS, they seem like they are fine on the short term. We don't know yet about long-term and very long-term effects. So I prefer to stick to insulin in the first and second trimester of pregnancy.
Great.
Have I missed something from your questions? There was something.
No, I just wanted to know, is the choice of treatment based on the trimester at which the diabetes is diagnosed? I mean, I think you've answered. I think you've answered by saying that if it is very early in pregnancy, you would prefer insulin over other treatments.
Okay.
And I would like to share that even I am an opinion that insulin is probably the best treatment if at all pharmacological therapy is required, because most of our gestational diabetes, what purely are due to pregnancy and definitely not present before pregnancy, because we have a lot of women who possibly have diabetes even before pregnancy, but it gets detected only during the pregnancy because that is the time they come to us. And probably glyburide or metformin, as per my experience, it can be an option to MNT if they're not sticking to MNT, but it cannot definitely be an option to insulin. I mean, none of these drugs in my practice are useful to alternate insulin. They can alternate MNT if it is not followed, but MNT if not, then insulin is what.
I absolutely agree with you. Yeah.
Yeah, Anjali, since Professor Hood asked the Indian colleagues to comment, if I can step in. First of all, this whole thing about diabetes is an add-on to our knowledge base and, practical base, because more and more cases are coming, and then, whichever way you detect it is a complex issue given the time constraint, because this is also becoming like in the real sense tsunami, because more and more testing is being done. So we test the women as per government guidelines at 2 points in time. If the test at 12 weeks shows hyperglycemia, then MNT fails, then insulin. If the test that time is normal, we have to retest at 22 to 24 weeks. At that time, if it is hyperglycemia, then again it's MNT, and then metformin, and then insulin. Here in the second half of pregnancy, it is recommended in the guidelines also. Glyburide is not yet in the Indian Government of India guidelines. That's the first thing. And secondly, still we would bring in that metformin in between, though many of our endocrinologist colleagues do not agree on that, because for us, the targets only we keep in mind. If MNT can bring us our targets, we are fine. If metformin we add on, then it gets us to our targets, then also we are happy. That's because millions of women, very difficult to put them straight away on insulin, bypassing the metformin, because the issues regarding hypoglycemic attacks, and then, the variety of monitoring that they have to do once they're on insulin. It's a huge challenge to the millions of pregnancy packet which we are dealing with as OBGYNs. Yeah, that's the reality.
Agree. I absolutely agree. If at all it can be delivered in a proper way, MNT can replace metformin. But otherwise, I think where the facilities of providing MNT are not as strong, metformin can work. Definitely. Would Dr. Kapoor like to mention anything about this?
No, I think I agree with what Hemaji said. I don't have anything further to add.
Can we have the next slide then?
You can keep
right.
going.
I think we've discussed, and we can go ahead to the next question slide.
Yes.
Yeah. So coming back to Dr. Hema again about the diet during pregnancy, I'm sure that we are having innumerable controversies about pharmacological treatment, which is probably more evidence-based than the nutrition guidelines. But still, we do understand that it's very important to understand the nutrition recommendations during pregnancy. So what are your thoughts? Is there ever a time that we prescribe a very strict diet during pregnancy? Do keto diets, intermittent fasting, and now that we are talking about nutritional manipulation, that what Dr. Hart said, would you like to add meal replacements or nutritional manipulation during pregnancy? Is it safe? Is it useful?
Anjali, these questions are like pregnancy or non-pregnant, anybody. This is for general.
No, this should be pregnancy specific, because
okay. Yeah. Okay. Is there any time where we prescribe the strict diet? See, again, in keeping with nutrition and weight first, we are really sensitizing all the OBGYNs to start thinking about, spend a minute or two, at least, raising the topic of the diet. It has now come in the checklist of the things to do in the antenatal, check that they have to mention about the diet. And hitherto, we are paying more importance with the government initiative of POSHAN program, where there's a huge India nutrition initiative where especially for the adolescent and the pregnancy targets, they have done a huge amount of work in various districts, doing different types of diet advices. So in pregnancy, what happens is when we pick up the hyperglycemia, we as OBGYNs still have to go a long way to very quickly learn to pick the correct diet advice. Patients themselves will Google, they'll see, a lot of things, and by hearsay and everything, sometimes they really get the fetus down to growth restriction even because of starvation, because they're so paranoid, because they get so psyched up with the diagnosis itself. And we have both extremes of patients. One who are complacent, taking our, whatever, with whatever conviction we tell them, they may not be compliant with the diet advice. The other extreme, pregnancy is the only time, as Anilji said, that they are very strict about what they want to do for the benefit of their little one. So they go overboard and get too strict on their diet, and that swing is, to the extreme. So yes, do we tell them strictly about diet? We are not spending enough time. We have ourselves not understood how to, quickly tell them the right things to do. About keto diet and intermittent fasting for obese women and all, I will again redirect this question to Moshe and Anil, because I wanted to look it up particularly for this panel. Then I decided not to look it up, because we don't usually, bring in these things in our practice. So
Pregnancy.
at the moment, I have no knowledge on this of what I should be doing with this advices on keto diet and intermittent fasting for obese pregnant women, if the question is specific to
Yes.
pregnancy. And meal
Yes,
replacement, sometimes I will ask Herbalife and all, can I take this? That is usually non-pregnant women. Pregnancy, they don't want to meddle with any of these things. That much that's the sense I get from the patient community for sure.
We do have some pregnancy specific or pregnancy safe meal replacement. Would you allow them?
I don't think that if the patient comes with the kind of question that would you allow, then we will be hesitant to just say yes or no because we don't know. So we would then seriously strike base with the nutritionist or a diet consultant and see this is the meal replacement that the patient wants to take. Is that okay? Is that not okay? Because I don't think I would just off my hat say yes or no on my own. That's the truth of the matter.
Because you mentioned earlier, Dr. Hod, would you like to comment on keto diets and intermittent fasting during pregnancy?
Yeah, it's very problematic. It's very, very debatable. And I'm not sure you can see it, but that was a congress that was held here last year in Tel Aviv. It was called Metabolics 2019. I was fortunate to attend and hear few lectures about it. And the ketogenic diet is, you probably, as you know, on your non-pregnant patients, that it's very, very promising. There are data about pregnancy from the late 60s, 70s. I'm not sure that later there were enough studies that were blaming ketone bodies and later fetal or neonatal childhood IQ deficiency. Now, I am not sure how these studies are robust and evidence-based, but still, we keep them in mind and we don't dare to prescribe the ketogenic diet to our patients during pregnancy. And reading lately more and more about ketogenic diet and GDM, there is even a book about GDM and ketogenic diet. And I invited the author to come to Saloniki and to give a lecture. We'll see, maybe it will happen. So yeah, it's debatable, but I won't do it at this stage. I am too reluctant to expose the fetus to ketone bodies. And we know exactly that my boss in Chicago, Norby Frankel, was the one behind the physiologic effect of accelerated starvation and facilitated anabolism. Those two phenomena are physiologic in pregnancy, because for a non-pregnant person to get on a starvation, it will take him over 24 hours to produce ketone bodies. For a pregnant lady, normal pregnancy, it will be enough to have 8 hours of fasting to wake up in the morning with ketone bodies. So the studies from the 60s and the 70s were dealing with an increased ketone bodies in the urine and decreased fetal neonatal IQ. Is it right? I am not sure, but I won't dare to use it now till we'll get more evidence that it's not harmful.
Right. So physiologically, we know glucose is something that is transferred from placenta, and insulin resistance is something that is physiological to pregnancy and exaggeration of his gestational diabetes. I agree. And I'm happy to know that we don't have to advise ketogenic diet to pregnancy, because even advising it to non-pregnant people is a task. So
if I may add,
yes, sir, please.
Ketones are not natural to human physiology. It's an unnatural thing that happens. And we don't want anything unnatural happening during pregnancy. That's one thing. The other thing, when you talked about strict diets, if you're talking of morbidly obese women who are pregnant, probably you may have to get to a level where you are ensuring that they are not gaining more than a few kilograms of body weight. In that case, yes, you may have to put them on very strict diet control. But then why are we then not even talking about bariatric surgery and stuff like that? Because those are also available to deal with these issues. So this is a complicated issue, and we need to look at it from the point of view of how big is the obesity problem in a given woman. If she is morbidly obese and has become pregnant, this is a very precious pregnancy. And then you would do everything possible to ensure that it is successful, including very strict diet regimen, control regimens. But I wouldn't go to the level of getting into a ketogenic issue.
Absolutely.
I'm going to start a study probably as a pre-pregnancy solution for obese ladies. Because then if we can manage to reduce their BMI and to get them pregnant in a normal BMI, I'll be happy to pay the price of a ketogenic diet, but then to stop it immediately as she conceives.
I guess that would be most ideal thing to do, because pregnancy is too late to do all these interventions, is what we
And
all
the
agree.
effect of ketones on brain, even in normal adult people, is very harmful.
True.
Then to accept that these ketones would impact a developing brain, people are looking at very short-term outcomes, not looking at long-term impact of what is being done to control blood sugars. I think it's very important that we understand that what we do during pregnancy has tremendous impact in the future.
Totally agreed. Totally agreed.
Dr. Anjali, Purvi here. I
Yes.
just had a minor comment, if that's okay.
Yes, please.
So I agree with Dr. Divakar when she talks about meal replacements and the question whether we should use them or not. The problem is the Indian women are so malnourished at times that using a meal replacement would actually be beneficial, because it ends up correcting the protein deficiency also. Because at least by that method, they are at least getting that much protein in, leave alone controlling the carb intake. So I find that personally quite attractive, and haven't used it in many patients, but I think I would, maybe some of you can comment on the use of meal replacements further.
Yes, I agree, Dr. Purvi. I also do use meal replacements during pregnancy, especially the ones which are commercially available for pregnant women. Definitely, we do not go beyond the recommended level.
Not beyond that.
Many of our women are protein deficient, and if commercially available pregnancy safe nutrition formula is available, it may not be a meal replacement as such, but it may add to the protein supplementation to the diet.
Maybe
exactly.
a mid-meal.
Yes.
Yeah, correct.
A snack replacement.
Addition is for protein supplements rather than a meal replacement as such for weight loss.
Exactly.
If you call it a protein supplement, Anjali, then there's a lot of it that we prescribe. Yes.
I totally agree. Yes, I agree.
Shall we move to Dr. Durga and the takeaways?
Yes, I think the next question is already addressed, so we can do that. This question is already addressed, so we can go ahead.
Yes, ma'am.
If we have time, we'll come back to these questions. Dr. Durga, please.
Yes, ma'am. Yes, ma'am. I'll try and share the slide.
Sharing your slides. Yeah. Great.
Okay.
Yes.
Let me just. Thank you very much for the wonderful session, the speakers. I'm going to just collate everything and give you 10 takeaways from this brainstorming session. Thank you, Dr. Usha, for giving me this opportunity. So 10 takeaways from this session would be: takeaway 1, NCDs are a slow motion disaster and it is programmed and imprinted during pregnancy. Number 2, the life cycle approach. Pregnancy is a window of opportunity, which is preconception management in the early trimester, prediction and prevention, and to prevent future NCDs in the postpartum management. Takeaway 3, universal testing, a one-step procedure. All pregnant women should be tested for hyperglycemia during pregnancy. Number 4, most widely used guidelines for gestational weight gain is the IOM guidelines. FIGO guidelines states that the normal weight and underweight women, the IOM guidelines apply. No definite guidelines for ethnic groups. Takeaway 5, when lifestyle modification fails, then metformin, glyburide, and insulin should be considered. However, glyburide is not in Indian guidelines. Insulin should be considered as a first choice of treatment in women with GDM who are at high risk. Takeaway 6, current glucose targets of 90 and 120 applicable for GDM women. If women with high risk factors or pre-gestational diabetes, the numbers can be altered to have a stricter control. Number 7, consider all patients with previous GDM as GDM during this COVID situation. Consider home monitoring, follow-up, and also home GTT. Even if the tests are normal, these women should be given lifestyle modification advice. Number 8, consider myo-inositol and vitamin D along with folic acid and calcium supplements. Also, as a part of non-pharmacological therapy, exercise should be included. Number 9, fasting blood sugar and 1 hour postprandial is considered as a monitoring monitoring. Choice of treatment depends on the trimester of pregnancies. When MNT fails, insulin is the choice in the first and the second trimester. Metformin can be used after 24 weeks, and glyburide is not used in Indian guidelines. Number 10, ketogenic diet, intermittent fasting are not recommended in pregnancy. Diet should be individualized according to the BMI and weight gain. Protein supplements can be considered which are safe in pregnancy.
Thank you so much, Durga. This is amazing. I think this has absolutely crystallized everything that we have been talking about for nearly 2 hours now. And this has been such a great discussion. I hand over to Purvi Chawla, who will now see if we have to answer any questions.
Sure. Thank you so much, Dr. Sriram. I think the 2 hours were a breeze. So excellent talk, Dr. Hord, and equally engaging discussions with the esteemed panel, Dr. Hema Divakar, Dr. Anil Kapoor, Dr. Sriram, Shalini, Dr. Shalini, and Dr. Anjali, with the amazing takeaways also, very clear and definite. But we still, and I must compliment all because we've received an excellent number of questions and comments from the audience. I've just gone through them and made a list, and from different parts of the country as well. So I think this has reached out really well. There's an observation from Dr. Manjula Bagri from Mumbai, and in her observation, obese women tend to gain less weight as per her observation during pregnancy. She also comments that metformin throughout pregnancy is what she has observed. People just continue that. But if it should be discontinued between 12 and 20 weeks, then we need to alert people more and there should be more awareness created for the same. This is her reflection. There's another comment all the way. There's another question all the way from Dibrugarh in Assam, Dr. Jashbir Roy. He wants you to just comment on what the relationship of thyroid problems with infertility. So it's not. So if Dr. Divakar wants to comment on that quickly, then we can move on to the other one.
It's whether I should respond is Usha's discussion, because it doesn't really fall in the framework. Again, as Anilji said, we use the pregnancy window as one of the opportunities to check for the thyroid status and treat accordingly. So most of the infertility centers, in their workup also, the issue of checking for thyroid and correcting it is the norm. So that is where it is. That's not, that may not be the cause of the, directly impacting the fertility potential of a patient. It is in the armamentarium of the checklist of the investigations that a patient has to undergo.
Can I give an endocrinologist viewpoint?
Yeah, please,
Yes,
please, Usha.
So if it happens to be a pre-gestational diabetic, and that's because it's usually type 1 and it's autoimmune, they have a very high incidence of coexisting hypothyroidism. So that is one association. And of course, though the Indian Thyroid Society recommends universal screening of all pregnant women, so we end up picking up a lot of people with subclinical hypothyroidism. So the correlation is just only, people usually think that treating subclinical hypothyroidism is only to improve babies' IQ and outcomes, but there is some connection with the mother's hypertension, preeclampsia, and also with the GDM. So, and of course, we follow the thyroid guidelines. So just some peripheral connections.
Great. I think that was well covered. There's another question from Dr. Jaya from Chennai, and she's asking if screening is negative for GDM at the initial visit, should we retest at 20 weeks or 24 or between 24 and 28 weeks? And then if that's negative too, should we repeat it at 32 to 34 weeks?
Anilji?
I think that was our last question, which was not answered. I am glad that question has come up. Yes, Dr. Kapoor, please.
Okay, so I would say that again depends on the risk factors. If there are very strong risk factors, then it should certainly be repeated again in the third trimester. If there are no risk factors, I wouldn't bother to repeat it. If at 26 or 28 weeks it is normal. But if there is a strong family history, or if the woman is obese or older age group or something, then certainly it should be repeated again in the third trimester.
One more comment. Moshe, please go ahead.
No, go ahead, Hema.
No, oftentimes, Anilji and myself have discussed when it is being brought to our notice that what's the use of doing it in third trimester? Even if it's positive, we are so close to the delivery date, and the short-term outcomes for the mother and the baby will be anyway. It's most likely to be all right if the first two tests are negative. But again, reflecting on the idea that it's a spotlight, as Anilji always mentions, thrown on this woman, we can keep track of her and her offspring for an indefinite period of time for the rest of her life, because potentially she has unfolded the situation late in pregnancy. That gives us a chance to pick up for the long-term care. So that's point number one. Secondly, in the Indian guidelines, the next amendment, we are likely to present the data to the government about many of the private practitioners who have done the test in the third trimester and picked up a significant number of hyperglycemics evolving even later. But the reason why this was not put on the table last time was that even today, though we recommend universal testing, the last NFHS data has shown that only 15.8% of our pregnant women are actually tested at least once. It's like the pap smear situation. Hardly 3% have undergone pap smear. The same way, even though 100% had to be tested, only 15%. We've not even reached a significant number for a single test, one-time test. So even though we've made it so simple for them to test it, it's not happening because of lots of constraints around logistics. So we feel that once we consolidate, we get all the 100% of our women tested in the present recommendation of first trimester and mid trimester, then we will move on to the next step. That's what we are thinking.
Imaji, that's perfectly fine. If the woman has not been tested, she should be tested at any point in time, at least once during pregnancy. The issue is that given the large population of women who are pregnant, recommending tests in every trimester for every woman is logically a very big challenge. And so from that perspective, my viewpoint is that from a public health point of view, I would say that testing should only be done in women who have certainly risk factors and where the clinician suspects that he or she might turn out to be positive. So that was my perspective. I would be glad personally if women are tested in every trimester to ensure that they rule out GDM in whatever. But from a public health point of view, it doesn't make sense to recommend it widely. And that's why I said only with high risk factors.
Yeah, because those who are already doing it always raise questions to us, why this recommendation is not there? Why didn't you all put it? Why didn't you suggest? That's the kind of questions that we are asked. And I think I entirely agree with Anil that the public health perspective doesn't come into a clinician's chamber in private practice. Large number of us. So it's a different, mindset that you require to do that perspective.
Absolutely. And it's the same guidelines across the strata. So
Professor
yes.
Hart wants to.
Yes, Professor
Moshe,
Moshe, please.
Yeah, I'll follow Anil. You forgot the fetus. So to whatever you said, after 28 weeks, if the fetus is over the age 75th percentile, the mother have to be tested again, because you said about risk factors, maternal risk factors. But if you follow the growth chart of the fetus, and the fetus is jumping from the 50th percentile to the 75th or the 90th percentile, it means that probably there is some dysmetabolism, and the mother has to be tested. That's the only other addition to what Anil said. The rest of it is great.
I completely agree with you, Moshe. Fetal growth charts are very important to even determine how often a woman should be tested.
And that's why we are coming with the FIGO guidelines on fetal growth. So be patient. In about 2 months, you'll get the FIGO guidelines on fetal growth.
I completely agree, Professor Moshe, because yesterday itself, I saw this lady who is almost 35 weeks. And she's been referred to me now because all her GTTs have been normal, but she's got polyhydramnios, So she's come back, and then that is where we're trying to pick up dysglycemia because, if she's monitoring at home, her fastings are still 80s, randoms are still 110s, but she's got polyhydramnios and the baby is 10 days up. So we do pick up those kind of findings. So I think there it just makes sense to look out for those missing links.
Yes, and the same thing has been raised by Dr. Vijayalakshmi also over here, that when we can't pick it up with GTT, what do you recommend? Because later scans may show increased amniotic fluid and...
there is this issue where we must understand that there is the fetal glucose steal syndrome, where the fetus has been producing a lot of insulin and is actually stealing a lot of glucose from the mother. So the mother actually appears normoglycemic, but may actually be diabetic. So there is a condition if the fetus has been, if it was missed out in the very early part, it is a possibility that the hyperinsulinemia in the fetus may actually be moderating the mother's glucose level and the fetus may be growing. And that is why what Moshe mentioned, monitoring the fetal growth is so critical to determine, and women may be absolutely normoglycemic, but the fetus is growing big, she's getting polyhydramnios, and the fetus is actually compensating for the lack of insulin from the mother, and therefore fetal growth. And I'm sorry that I did not mention it the first time. I only talked about maternal risk, And thank you, Moshe, for pointing that out.
Anil, it shouldn't happen. You are an obstetrician now. So please.
So then, my
What do you recommend the management should be of
Yes.
such women with GDM, diagnosed in the third trimester, and they are so close to
I
delivery?
think some insulin helps them. So we'll ask Professor Hord about that.
Mujik,
Yeah.
questions to
No,
you.
can you repeat it, please?
So how do you manage GDM when they're that close to diagnosed in the third trimester and very close to delivery? What is your recommendation?
It's a huge problem. Me as an obstetrician, my main task will be to decide about the timing and mode of delivery, because there is not a big chance that I'll be able to modify fetal growth. If it's already on the 75th, 90th, 97th percentile, the chances that I'll be able to reduce it again to the 50th percentile are very, very low. We don't have the span time enough to do it. So in these cases, as we all wrote in our guidelines, I will do an evaluation at 38 weeks, because 38 for me is quite safe in sense of fetal lung maturity. If the fetus is AGA is less than the 90th percentile, then I'll even try and induce labor between 38 and 39 weeks. But if the estimated fetal weight is over the 90th percentile, then I will probably go for an elective cesarean section. It's controversial, it's debatable, but that's what I do. And I'm quite happy with what I'm doing.
Moshe, I'm not an obstetrician, but I would also like to add one thing, that it is also very tricky for a fetus that has been growing at a certain rate, that when you start correcting the maternal glucose level very quickly, you might risk stillbirths, because the fetus is used to that kind of glucose levels, and it might have an impact. So we need to find the right balance between how tightly we start to control in the later part of the pregnancy. It might have consequences.
I absolutely agree. And that's why I want to add another very important caution. About 36 weeks, be aware that glucose values can go down. And they go down because at 36 weeks, insulin resistant, that's mainly produced by placental factors, are getting older. So insulin resistance is going down, thus maternal glucose values may go down as well. So be careful. You have to monitor your patients. Sometimes you have to reduce your insulin dose. Sometimes you have to increase the number of NSTs or fetal monitors that you do. But you have to be very careful between 36 and 39 weeks of pregnancy.
Fantastic.
So then what should be your line of management to a GDM who's come to you with something like a 180, 190 kind of a glucose, or touching even 160, anything from 160 to 180? So then do you treat it, or do you just leave it at that at 36 weeks or 37 weeks? Or do you give some insulin? How do you lower the glucose levels at this point?
I treat her, but I don't expect a very positive outcome on the fetal side, which means I don't expect the fetus to come down from the 75th or the 90th percentile down.
Exactly.
But I still want to keep the mother as normoglycemic as I can. I want to bring her to delivery. She has to be during the delivery normoglycemic.
Yes.
Because her status during labor and delivery will be actually what will cause the neonate to be normoglycemic as well. Yes. And sometimes it's not enough. That's why you have to monitor the neonate for at least 24 to 28 hours. The first 24 hours are very crucial. They have to be monitored for neonatal hypoglycemia. because still they have very high insulin levels, but they were disrupted from the high glucose transfer from the mother. So these guys are prone to develop neonatal hypoglycemia. So you have to work hand in hand with your neonatologist and have a very, very good protocol of follow-up and management of the offspring of the diabetic mother in the first 24 to 48 hours.
Do you
Great.
think, Dr. Kapoor and Dr. Moshe, that we need to have an alliance with the pediatricians as well to follow up these children who are born to GDM mothers or diabetic mothers?
You have to, and that's something that Anil will probably say a bit more about it, because he was the guy behind it. Yes, we want to form alliances with, but I let Anil deal with it. Please, Anil, go ahead.
I think 2/3 of the job of detecting GDM is postpartum care and ensuring lifelong guidance to the mother and the baby. And that is something that we always miss upon. So when we talk about life cycle approach, I say this is like a relay race. You have to pass on the baton to the other. And one of the things that we have been suggesting in FIGO and many other places is to link it with the vaccination of the child. So at least for 5 years, the mother would come at certain points in time with the health system. And that is the time to guide the mother about her own weight, about continuing breastfeeding, about why it is important for her to eat healthy, and why it is important to ensure that the baby remains healthy and is vaccinated and prevent all kinds of initial problems. And so linking it with the vaccination program is very important. And as I say it in meetings, I say in India, women put bindi on their forehead, take that bindi out from her forehead and put it on the child's well baby clinic card, and say that this child is an offspring of a GDM mother, and therefore when that child is brought for any other purpose, at least for 5 years, you also pay attention to the mother and also to the child.
That's a great analogy, Dr. Kapoor. And in the interest of time, I'd like to shift gears a bit and go back to tracking dysglycemia. And there's one comment which is quite interesting, and we haven't discussed that in detail yet, from Dr. Jayashree Gopal in Chennai. She mentions that CGMS values always underestimate capillary glucose. So how do we extrapolate CGMS values to the recommended targets that we typically give on venous values? Dr. Moshe?
I was distracted. I apologize. Can you please repeat it?
So the question is about correlating CGMS findings to the recommended targets in pregnancy. What is your comment on that?
It's very difficult, very difficult. You know, we have some algorithms comparing between, in practical practice, what I do sometimes, but I am in doubt, practical, not a recommendation. You can't put it in the guideline. I send my patients twice a week or 3 times a week to the laboratory and have her check her blood glucoses concomitantly, a finger prick and the plasma glucose value. And then that's especially when I have to make a decision whether I have to start treatment with oral hypoglycemic agents or whether I have to pass from oral hypoglycemic agents to insulin. But usually I do rely on continuous glucose monitoring. The Libre with type 1 patients is very, very good for me. I rely on it, but I know that the values are sometimes terrible. So that's why I'm sending them a few times a week to check their blood glucoses, mainly fasting, and then make my decisions. But it's not good yet. Hopefully, the continuous sensor, non-invasive, will be a good one. We compared it to the Libre, and it looks very good. Looks very, very good.
I think that's a very good point, Purvi, that periodic validation of the CGMS with home glucose monitoring and even with the lab is really And for each patient, there can also be inter-subject variability in the difference. That's what we're seeing. So we must have a validation periodically. That's a great.
Absolutely. Even with the freestyle, I mean, with the Libre Pro that we have in India, I think what we do is we change the range of the TIR. But yes, we need specific studies to look at that in pregnant women, and also recommendations specific to CGMS.
So I think we are out of time, I think. We were supposed to end at 8:30. We've gone past that, and this has been such a great session. I cannot begin to thank Professor Hort for sparing 2 hours of your valuable time. Thank you so much. And also, I think you've given us some brilliant suggestions for what we can do in our country. And to Hema, oh my God, Hema and Dr. Kapoor for being such great, friends of us and what we do. And all the beautiful, beautiful colleagues that you see on screen and ones you don't see on screen, who've actually been the power behind this program. I thank you all so much for this. And also you will see, names of some of our pharma colleagues who not only, they really have also used their database to just promote this program. That is really what they've done. This is completely free to all delegates. I really appreciate all of you being here today. Thank you so much. And I just want to end by saying something to Professor Hort. I have a connection to Northwestern. I became an endocrinologist because of Professor Sheldon Wallstein. Shelley Wallstein from Northwestern. He came and made grand rounds at my institution and motivated me to become an endocrinologist. So, and tomorrow Mark Molich is doing the PCOS and prolactin, and we look forward to that.
Please give my regards to Mark Molich.
Yes, it's another amazing session awaits. Tomorrow awaits another great session. I invite everyone who has joined today to join in tomorrow as well. Thank you so much, everyone.
Thank you so much.
Thank you very much, Usha, for a great opportunity to meet Moshe and Anil, whom we can't do without seeing each other for long. Thank you very much.
Thank you, guys.
Thank you. Thank you.
Bye-bye.
Thank you, Dr. Usha.
Thank you.
Thank you.
Bye.
Thanks, everyone.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am. Bye.
Bye.